Good morning, everybody. Thank you very much for that kind piece of introduction. And let me thank the Kandy Society of Medicine, the president and two secretaries putting me in trouble into 3 days to prepare this lecture of anaphylaxis. And thank you very much. So I'm going to talk about, I have been given only 45 minutes. So I'm going to talk about practical approach to management of anaphylaxis. This is basically practical approach, and theory part is also there. The slides about 180 slides, but I'm not going to talk all of about that. I'm going to talk about the practical approach. Yeah. Right. So sorry about that. So I'm just going to do the brief introduction and pathophysiology and clinical features, investigations and management of it. So anaphylaxis is the most dramatic and potential fatal manifestation of immediate hypersensitivity, accounting for more than 500 deaths annually. This is 500 deaths annually global data. So what is an anaphylaxis? Anaphylaxis is a severe, life-threatening, generalized or systemic hypersensitivity reaction. The term anaphylaxis has been used for the type of acute life-threatening illness. This is very important in the later lecture in the later slide, because you need to identify, you need to diagnose what is anaphylaxis, and there are anaphylaxis mimics also. So which triggered by abnormal sensitivity, or it sometimes could be idiopathic anaphylaxis. Little bit of pathophysiology is, you know about it, Ig mediated hypersensitive reaction to an antigen. And this leads to profound histamine and serotonin release from the basophils and mast cell degranulation. What are those chemical mediators? Histamine, tryptase, chymase, heparin, and thymoglobulin. But what important thing is, it causes the vasodilatation, intense vasodilatation, and tissue fluid leaking, so edema, causing angioedema, bronchoconstriction, increased mucus secretions, and changes in myocardial contractility. What are the etiology? A little bit about the etiology. Food is a mainstay. The peanut is very common in other countries, but not much very common in Sri Lanka. And seafood. And drug wise, yes, it's antibiotic, the penicillin group, or whatever the drugs, it could be anaphylactic, allergic to the people. So an NSAIDs or narcotic drug, anesthetic drug, and opioid. Sometimes some patients are allergic to even piriton and to hydrocortisone as well. And venoms, stings, latex, blood and blood products. So these are just a theory about the etiology. So this is the signs and symptoms. This is very important. Why? The patients come with various clinical features. If the given context of suspecting anaphylaxis, you might encounter one of these features. It could be a lightheadedness, confusion, anxiety, or shortness of breath, wheezing. You might think that is an exacerbation of asthma, or may not. And cough, and the patient's abdominal pain is a cramped abdominal pain, diarrhea, and vomiting, which is also a clinical feature of anaphylaxis. And loss of incontinence and pelvic pain, lower abdominal pain, is a symptom of alarming symptoms of anaphylaxis. And skin, you know about itchiness, hives, and flushing. Vascular system, we have a system, we have low heart rate, and hypertension, and angioedema, runny nose. So these are the clinical features. But when you look at the clinical features, there are mild form, there are moderate form, and there are severe forms. So mild form of allergies, so patient come with skin and subcutaneous tissue involvement only. It's a generalized erythematous or urticarial rash, and probably they begin with sensation of warmth of all over the body, and then which can lead to the severe hypertension. And sometimes they feel feeling of anxiety or panic. What do they explain? Usually they say, the patient say, something going to happen to me. Is something going to happen? If you make it Srinagar, they say, Dr. Mata Mokaddo Vendana. That is a very alarming symptom, they say. And moderately, they get the sensation of dyspnea, bronchospasm, and a sensation of pre-syncope, and GI disturbances like nausea, vomiting, and diarrhea may occur. So they come with develop the angioedema and resulting in stridor and rolling. And severe form, they develop the hypotension. Hypotension, systolic blood pressure less than 90 in adult, and they might have a collapse, arrhythmia, cardiac arrest, and altered level of consciousness and confusion. Important thing, note that the onset of severe clinical feature may be extremely rapid without prodromal features. That is, you have to remember. The median time interval between onset of symptoms and the respiratory or cardiac arrest was 5 minutes in the iatrogenic anaphylaxis. This is within 5 minutes, everything done. So what are the systems involved in anaphylaxis? Skin and subcutaneous tissue, cardiovascular system, respiratory system, and gastrointestinal system. Right. When we look at the clinical features, it's important to note that the previous history of a patient. They might give any clue, the anticipation of previous history of an allergic reaction to anesthetic drugs, antibiotics, or cutaneous sensitivity, rashes, especially the hair dyes. So be very careful when you are giving antibiotics or drugs for those patients. Now, this is the clinical definition of anaphylaxis. There are various discussions about this one. There are various guidelines, UK guidelines, Australian guidelines, New Zealand guideline, but I'm basically adhere to the Australian and New Zealand guideline, more or less the same clinical. This is very important. I'll read word by word. Acute onset of illness with typical skin features, urticarial rash or erythema, flush and angioedema, plus involvement of respiratory and cardiovascular or persistent severe gastrointestinal symptom. That is one. The second one, or any acute onset of hypertension or bronchospasm or upper airway obstruction where anaphylaxis is considered possible, even if typical skin features are not present. For example, a patient coming to you with past history of allergies. So you have given some medication. If this patient has developed hypertension or bronchospasm, you can diagnose this patient as most probably anaphylaxis. You don't need to get the skin rashes. Don't wait until the skin rashes appear. So the skin rash not appear only about 20% of the patient. They don't get the skin rashes. So if you suspect a patient with past history of allergy and given antibiotic or something, so hypertension or bronchospasm or upper airway obstruction is that itself enough for you to diagnose anaphylaxis. Right. Now there are three categories of patients coming to you. One, exposure to known allergen. Two, exposure to probable allergen. Third, not exposed to obvious allergen. Exposed to known allergen, the patients come to you, doctor, I'm allergic to peanut or beef or mutton, so I have accidentally taken them, so I develop these features. So that is exposed to a known allergen. Exposed to probable allergies, sometimes they say I have no allergies, but I have taken a meal from outside, which is a bit of strange to me. So the patient can come with the features of syncope or hypertension. That is a probable allergy. And not exposed to obvious allergen. Some patients coming to you, there's no history of allergies, no history of exposure to allergies. So those patients are very difficult to diagnose. But there are criteria for us to diagnose. Right. So exposed to known or probable allergen, one of the following features is enough even in the absence of clinical involvement, skin involvement. Even in the absence of skin involvement, you can diagnose this patient exposed to a known or probable allergen. That is the hypertension, bronchospasm, or laryngeal involvement. That itself enough for you to diagnose anaphylaxis. Right. exposed to a patient exposed to a non-allergen, we talk about the hypotension. So what we mean by hypotension is the systolic less than 90 mercury millimeter, or if the systolic blood pressure less than greater than 30% reduction from that patient baseline. If a child, so greater than 30% reduction in systolic blood pressure considered as a hypertension in that context, right? Then they're not exposed to obvious allergen or no history of allergies. So this patient doesn't give a history of allergies, and patient doesn't give a history that he has not exposed to any allergen, any allergens recently. So involvement of the skin, mucous tissue, or both is simultaneously with one of the following: either respiratory, the cardiovascular, or persistent GI symptoms. So the involvement of skin in this context is necessary. Why? There are anaphylaxis mimics. So it could be a drug reaction. The drug reaction is different from anaphylactic reaction. It could be a toxins, or it could be a cardiogenic shock, myocarditis. There are so many other differential diagnoses. So that is why they have given, if you are not exposed to an allergen, or you are not exposed to non-allergen or no history of allergies, skin involvement is mandatory. What are the differential diagnoses in anaphylaxis? So tissue swelling, this could be idiopathic urticaria, or angioedema, idiopathic or angiotensin AC inhibitor related, or hereditary angioedema, and the sepsis, and the other thing, anxiety or panic attack, acute asthma exacerbation, they can come with the bronchospasm, anxiety and panic, and also some neurological symptoms like the epileptic seizure, vasovagal symptom. We might tend to diagnose these days, probably we tend to diagnose this anaphylaxis after you give something. And cardiovascular system, acute coronary syndrome, or cardiogenic shock, cardiac arrhythmia, probably these are the differential diagnoses. So one of the common thing, before injecting something or immunization clinic, you will come across a lot of patients get the fainting attack. So that is not anaphylaxis. How do you differentiate these two? Now, if the patient is onset of signs and symptoms in the fainting attack, so even they say that I'm just bit of faintishness even before the immunization, or while the immunization, or sometimes after the, during the just after immunization. The anaphylaxis they don't get before the immunization, but generally within minutes after the immunization, and even could occur after a few hours after the immunization. And skin and mucous membrane in fainting attack, they get generalized pallor and cold and clammy hands, but they don't get in anaphylaxis. They get itchy rash, angioedema, and urticaria. And in the respiratory system, usually the fainting attack rate of respiration is normal or shallow breathing, but in anaphylaxis they get the rapid respiratory rate, increased respiratory rate, or difficulty in breathing, wheezing, and stridor, where you can identify whether the patient is a fainting attack or anaphylaxis. And cardiovascular system, the fainting attack, in the syncope, reduced heart rate is possible, and weak pulse, and they have a transient absence of peripheral pulse. But in the anaphylaxis, they have the increased heart rate and weak pulse, but the patient significantly having a low blood pressure. And the nervous system, the faintishness and light headache is common in fainting attack, but the patient is a bit of anxious in anaphylaxis, and some become unconscious. In fainting attacks, if you keep the patient in lying down position, they might improve without giving anything during the fainting attack. And the digestive system, fainting people or the fainting attack, they get probably just mild vomiting, but in anaphylaxis, they get diarrhea, vomiting, and abdominal pain. What about the investigations? In an acute, in emergency setup, we don't expect you to take any investigation because there is no 100% diagnostic investigation in anaphylaxis. But in a research purposes, we can get the tryptase level. We can get the tryptase level at 0.2 hours and 24 hours later. But even the tryptase level, if the tryptase is positive, you can diagnose this as anaphylaxis. But if it's negative, you can't say that's not an anaphylaxis. So in the research purposes, we can get a tryptase level. But nowadays, because of this incident, that should be discussed. whether to safeguard ourselves, because now if a patient had a cardiac arrest or some other reason, the public will blame us that this is anaphylaxis which doctors have not managed very well. So in that setting, probably for our safety, we might have to take the blood sample and send the MRI for future purposes or litigation purposes to get the tryptase trace level. And whether he can diagnose it, then we are safe. It is not, I mean, we can't exclude, but at least we can say that this is not anaphylaxis. Right, these all are clinical features and the investigation. Now we'll come to the next part. I have another 20 minutes. Right. So far, I think medical student and all can understand. It's a simple thing. Emergency management in initial treatment, just a call for help. Very important. You can't manage anaphylaxis alone. Even we don't manage in emergency department all alone. And the stop administration of any suspected medication is very important. Immediate attention to the ABC issues and administration of adrenaline. I talk one by one later. And insert the large bore cannula and start normal saline boluses 20 ml kg up to 50 ml per kg you can give. The insert large bore cannula mean 14 gauge or 16 gauge, not the peripheral, at least antecubital for adult. Usual treatment is this patient is having hypoxia, bronchospasm, cold peripheries, tachycardia or bradycardia, low GCs, but we have to do oxygen, crystalloid, inotropes, vasopressors, bronchodilators, or see how it works. Right. Call for emergency team is very important. Emergency or that specific to manage that anaphylaxis is a team approach. One person can't manage this anaphylaxis because it's a dreadful situation. Team means a team ready. We have to. This is the responsibility of all the senior doctors, including consultant. Now these days is a very difficult situation, and you have to prepare your team. Doctors, the nurses, minor staff, or you have to prepare your team for an emergency. Get ready with the team and the equipment ready. There should be a ambu bag, oxygen, IV cannula, laryngeal mask, defibrillator. Those things should have to be ready, and the arrangement should be ready. So because no point keeping that linen thing somewhere locked in the cupboard, you have to arrange it properly to take an emergency situation. And the medication, especially saline and adrenaline, that is enough, because this is a teamwork. You have to become a part of this team, or otherwise, unfortunately, you have to become a part of this team. So you have to select which team you belongs to. Right, the management. Stop administration of any suspected medication, especially the blood products and antibiotics. And you have to, so these patients coming to came to the emergency department with a wasp bite. While we are resuscitating this patient, you can see that the patient is angioedema is developing. While we are resuscitating the patient, we have to remove the patient's sting also. You have to scrape it out because this is a difficult situation. So remove the allergen. That is the first thing which you have to do. No need to run here and there. Just stop your saline, no blood product. And this time I'll take the opportunity. I know all the doctors are busy, but even in our time, the wrong thing what we did, and the people are doing, you are busy. Probably you are in the clinic. You check the blood product in the clinic and ask somebody to start the blood product in the ward. That is happening, but don't do that, because this is a life and death situation. So if anaphylaxis, death occur even within 5 minutes. This is the message to junior doctors, the medical student. So don't do. And also, if it is not very urgent, if not life-threatening, it is better not to start blood and blood products middle of the night, or or the antibiotics, unusual antibiotic. Don't start unless getting your senior's opinion. That's the message I want to give. And even that, just read this one. Now, legality and the litigations will come to us also. This is the meropenem for injection, sodium chloride injection should be administered by intravenous infusion of approximately 15 to 30 minutes. So if you give a push doses, if you give fast bolus, that is your fault. Because manufacturer has clearly mentioned this has to be sent in 15 to 30 minutes. We can't blame to these meropenem people who produce this, manufacturers. So they have clearly given that you have to follow this manufacturer's leaflet. And the next one, for intravenous injection, dissolve in the injection 0.5 to 5 ml and 1 gram in 10 ml water for injection. The intravenous administration should be given over 2 to 4 minutes. You have to give over 2 minutes, 2 to 4 minutes. You can't give it as a push doses. If you are given, that is your fault. And last one, adult loading. So this is the penetrant sodium, 10 to 15 milligram per kg, rate not exceeding 50 milligram per minute. So you have to make that calculation according to that. But if you are given this patient this as a bolus, so the problem comes to you because you have not followed the instructions. That also be very careful these days. Right. Immediate attention to the ABC issues. The airway management is very difficult in anaphylaxis. Rapid assessment is necessary, and intubation should be performed by a very senior, not the person who's competent in intubation. And also, if you can't, please prepare the surgical airway or anterior neck access or the cricothyroid puncture. Be ready with that, especially in anaphylaxis coming with angioedema. Difficult to intubate. So you need the help. And other important thing, after your ABCD management, positioning of the patient. So suppose in the ward you have given antibiotic or something, the patient become unconscious or complaining of bronchospasm and faintishness. Don't keep the patient upright position. Supine position, recovery position. You can elevate the limb, but not the head low position. Not the head low position, but the supine position. Right. And this is very important. If a patient's kept upright or moved to an upright posture, death can occur within seconds. This is called empty ventricle syndrome because ventricle has no blood at all. If you keep the patient upright position, patient going to either asystole or pulseless electrical activity. You should be able to manage this patient because the ventricle is empty. So don't keep the patient upright. Don't ask the patient. If the patient says, I have this problem, I need to urinate, I have to go here, okay, go and come. Don't ask the patient to do that. So best thing is to keep the patient in supine position. One of my friends asked, Nandana, what are you going to talk about anaphylaxis? Just give adrenaline, not the adrenaline. Before giving adrenaline, you have to consider concern about these factors. Once the patient got cardiac arrest, it's very difficult to resuscitate with anaphylaxis. Alright, the prompt assessment and treatment is critical anaphylaxis because respiratory and cardiac arrest occur within minutes. And the other thing, anaphylaxis is very responsive to early treatment. It's very responsive, and the delayed adrenaline injection is associated with these fatalities, all fatalities. Now, what is the drug? Adrenaline, the 0.5 milligram intramuscular IV, right? We'll talk about what is the beauty of adrenaline. Why not noradrenaline? Why not dobutamine? Why not dopamine or vasopressin or whatever? Because adrenaline has alpha-1 receptor effect, which causes increased vasoconstriction and low doses, and increased peripheral vascular resistance, and increased blood pressure, and decreased mucosal edema. It decreases the angioedema. And beta-1 receptor increase the heart rate, that's a chronotrophic effect, and increase the force of cardiac contraction, that's inotropic effect. And on top of that, beta-2 receptor that decrease the mediator release from mast cell and basophils. That is the one of the advantage why we use adrenaline, not the noradrenaline. Noradrenaline also you can get the vasoconstriction, but adrenaline there's additional effect of because of beta-2 receptor action. It decreases the mediator release of the mast cell and increase bronchodilation, increase vasodilatation. That is why we use adrenaline. Now, adrenaline is, you know this one, 1 ml contain, we call 1 in 1000, 1 ml contain 1 milligram or 1000 microgram. Administration of adrenaline should never be delayed if you diagnose anaphylaxis. Suppose you write on the BHD, query anaphylaxis. These are legal things. And query anaphylaxis, and if you give hydrocortisone or Piriton, that is your fault. If you have written query anaphylaxis, manage accordingly or something, you can't play with that patient. You have to give adrenaline. That is a legal matter. You can't give hydrocortisone or Piriton. So don't delay if you diagnose anaphylaxis with giving adrenaline. Right. It should be given anterolateral aspect of the thigh, because injecting intramuscularly to lateral thigh is possibly slightly more effective than the deltoid. So we used to anterolateral aspect of the thigh. So 0.5 milligram. And if doesn't settle with 0.5 milligram of IM adrenaline, don't dilute adrenaline for when you are giving IM, and you can repeat in 3 to 5 minutes interval. You can give the second dose if there is no response to IM adrenaline 0.5 milligram. Right. Now you have given adrenaline at anaphylactic patients. So you have given adrenaline first time, no response. Then they have given the second dose, still no response. IV adrenaline infusion in now the clinical settings. We'll look at how we start IV adrenaline infusion in ward setup. So everybody don't have infusion pumps in your ward, and the local hospital even they don't have a burette set, right? If there is inadequate response after 2 to 3 minutes of adrenaline, you have to start IV adrenaline infusion with the liaison of some senior fellow. And IV adrenaline infusion should be used with a dedicated line. You can't give the saline, no other drugs, with dedicated line of adrenaline. No need to insert central venous CVP line. So you can use the peripheral line. You can use the peripheral line in this emergency situation. But IV boluses of adrenaline are not recommended without specialist training, as they may increase the risk of cardiac arrhythmia. So this is, some people grant this as not to give IV adrenaline. But in our setup, in our ward or in this hospital, there are many people for you to help. So I think until you consult a specialist or somebody who is managing, or either ETU or theatre or anesthetist, I think you can start IV adrenaline infusion. That is my opinion. But because you know how to manage cardiac arrhythmias, or if not, so you have to get the training of managing cardiac arrhythmias by doing advanced life support course. So they don't, this guideline, but they specially mentioned about using IV adrenaline infusion should be done by a trained medical officer. Right. How do we prepare adrenaline infusion? Now other countries, they have 1 liter bags, but we don't have 1 liter bags. We have 500 ml normal saline bags. Other countries, they recommend 1 milligram of adrenaline put into the 1000 ml of normal saline. But in our setup, we have to take 0.5 milligram of adrenaline to 500 milligram bag of normal saline. Right, that is one. And you have to start the adrenaline infusion 0.1 microgram per kg per minute. So that is the infusion rate, 0.1 microgram per kg per minute. Suppose the patient body weight is 60 kilogram and dose of adrenaline 0.1 microgram per kg per minute. For that minute, we have to send 6 microgram per minute. That means 6 ml per minute. So we have how to make a 1 ml to be equal to 1 microgram. That is 0.5 milligram of adrenaline. That's 0.5 ml. We have to put in the 500 normal saline. So 1 ml contain 0.1 microgram. So 6 micrograms per minute or 6 ml per minute. If the 60 kilo person, so if the patient is having for hour, the 6 ml per minute per hour, you have to send about 360 microgram per hour. That means 360 ml per hour. The problem is, in the ward setup, how do you calculate this 1 ml? That is a drop factor. In the large normal saline, at normal saline IV drips, 1 ml equal to 60 drops of clear fluid. The 60 drops. But if the blood or thicker fluid, it is 15 drops equal to 1 ml, otherwise 20 drops equal to 1 ml. So now you know how to send a 360 ml per hour of that person. So every 2 to 3 minutes, if there is no increment, if there's no improvement, you have to increase the infusion rate by approximately half of the starting dose until you get the blood pressure to a satisfactory level. That is, we start with 6 ml per minute, and if there's no response, after 2 to 3 minutes, you can just 9 ml per minute. But it's still not working, you have to get that 12 ml per minute. So this is so simple. Right. In the pediatric, this is the guideline, Royal Children's Hospital, Melbourne, Victoria, and the courtesy of them, I have downloaded this one. So this is the dosage. The intramuscular adrenaline is 10 microgram per kg per minute, or 0.01 ml per kg of 1 in 1000, and this is according to the body weight and age. They have given the doses. So keep this one printed. You can download it and keep in your ward, because this is very important. Otherwise, you are finding another 1 or 2 hours to find the correct dose. How about the peripheral IV adrenaline infusion in pediatric? So you have to mix 1 ml of 1 in 1000 adrenaline, 1 in 1000 adrenaline in 1000 ml of fluid. The suitably, it is what they say is 5% glucose or 10% glucose, because and added glucose to the normal saline. Start infusion of 5 ml per kg per hour. This is equal to 0.1 microgram per kg per minute. Note it down and go and do the calculation. The same thing comes. And there also you need to have a dedicated IV line. And please consult your senior pediatrician or intensivist, because this is very difficult to manage, especially when it comes to the intubation. Right. So this is the starting of infusion in a ward setup. But there are other ways of starting with the infusion pumps. We were said that in that time you have to consult the specialist in that regard. So this is another entity which I am going to talk to you. Cardiac arrest in anaphylaxis. What do you do in cardiac arrest in anaphylaxis? Early intubation is particularly important according to the European Resuscitation Council guideline, and ensure surgical airway, and make sure nothing to do with 0.5 milligram IM adrenaline in this context. Now patient is cardiac arrest. You have to see whether the patient is shockable alarm or non-shockable alarm according to the advanced guideline, and you have to give 1 milligram, that is 1 ml of IV adrenaline flushed with normal saline 20 cc. That is the starting point of giving correct adrenaline in a cardiac arrest patient with anaphylaxis. Or 1 in 10,000 10 ml you have to give. No IM adrenaline in the cardiac arrest patient. No point giving IM adrenaline, IV adrenaline. And after that you have to follow the protocol according to the shockable alarm or non-shockable alarm. Most commonly IV anaphylaxis, they get assistant and pulseless electrical activity. So this you have to advanced life support, this you have to go through. Okay, last few minutes. And cardiac arrest in anaphylaxis, is there any place for antihistamine and steroid? These have no role in cardiac arrest. So be prepared for the cardiac arrest after anaphylaxis, prolonged resuscitation. You might have to resuscitate even 1 hour. In our experience, even 1 hour after resuscitation, patient recover, but you have to strictly follow advanced life support protocol. Okay, case scenario. I just give few cases. A 35-year-old gentleman with both asthma and a food allergy. He presented with breathlessness started during meal. He has self-administered his salbutamol inhaler and 300 microgram of adrenaline, that is EpiPen, auto-injector, with reasonable response. Pulse rate was 104 and blood pressure 75/50, respiratory rate 28, saturation 90% on air, trachea central, lungs bilateral wheezing sound. Is this asthma exacerbation or anaphylaxis? Both respond to auto-injector. Even the asthma respond to IM adrenaline, to there is some satisfactory response. So what is this? Right, okay. If this is asthma patient to have a hypotension, I think PGTNs might know, it should be near fatal asthma or life-threatening asthma. That's the one differential diagnosis. Or if not so, it should be a tension pneumothorax after asthma. But this history clearly say bilateral wheezing and trachea central. So unlikely tension pneumothorax, unlikely asthma exacerbation. So this is basically anaphylaxis. Case 2. A 62-year-old patient on beta blockers that presented with history of lower leg cellulitis, an examination pulse rate 110, blood pressure 90 by 42, respiratory 20, saturation 100, and they have started antibiotic. The patient developed syncope, pulse rate 120, tachycardia, blood pressure 50. So this is clearly probable exposed to probable allergen or known allergen. So this is basically anaphylactic reaction. And call for team stop antibiotic, give IM adrenaline 5 mg, 0.5 mg IL, elevate the leg, start the crystalloid immediately. Right? Case 3. A 16-year-old girl with a non-food allergy present with breathlessness and anxious in a restaurant. Paramedic crew has given IM adrenaline 0.5 mg because this patient has a history of food allergy. On arrival to EDE, pulse rate 110, blood pressure 110 by 65, respiratory 30, saturation 100. She has an urticarial rash on the chest. Do you justify giving adrenaline to this patient? So just merely the presence of skin rash won't diagnose anaphylaxis. There are 3 other criteria. Either angioedema, hypotension, there should be. So this patient just could be an anxiety. So this patient, though only the skin rash, blood pressure is normal, there's no point giving adrenaline to this patient. Observed this patient might develop anaphylaxis later on, but take the patient and start monitoring the patient. Another entity, adrenaline, last 2-3 slides. Adrenaline therapy and beta blocker treatment. So this is the non-cardiac selective beta blocker can significantly enhances the pressure response to epinephrine. That is well known to others because unopposed alpha adrenergic effect causes the severe vasoconstriction and increased blood pressure. What happened? Beta blockers and anaphylaxis. Beta blocker may attenuate the response of adrenaline or epinephrine in the treatment of anaphylaxis, where adrenaline won't work most of the time. Say, it might not work with adrenaline in this context. So we have to use another medication. If your patient is not responding to the adrenaline, 1 or 2 IM adrenaline and the infusion, guess the history whether the patient is on beta blockers. If the patient is in beta blockers, you have to reverse it with glucagon because it reduces the bronchospasm and it increases the cardiac inotropic activity and might helpful in the management setting. How do you give glucagon? Glucagon 1 to 5 milligram IV over 5 minutes and followed by infusion of 5 to 15 microgram per minute. Not the weight, according to the weight, is 5 to 15 of microgram per minute. That is how we give glucagon. But glucagon is not so available. Even now they have 1 or 2 vials. The problem with giving glucagon, they develop severe vomiting, so you have to act accordingly. If you don't have glucagon, patient with the beta blocker, we might have to start noradrenaline infusion if it's not responsive to adrenaline. Right. Now we have managed the patient. What of the further management? If the arrest advanced life support, what is the place of nebulization of adrenaline? If the other parameters are okay, angioedema, there's a place to nebulization with salbutamol with 5 vials, not a 1 or 2 vials, don't dilute. 5 vials of adrenaline with the 5 ml of adrenaline 1 in 1000, you can do the nebulization. The rest of the management and IHDU care. What about giving hydrocortisone and chlorpheniramine in emergency setting? Sorry, don't waste your time, draw or mix up hydrocortisone, no, chlorpheniramine in the setting of anaphylaxis. It won't work. Start work about 1 or 2 hours later. This is a few entities for the PG training center. What is Cooney syndrome? This cause defines a cardiovascular symptom that occurs secondary to allergic or hypersensitive reaction, insult. It's a rare, very rare occasion, but these patients with even with allergies and anaphylaxis, they get the very low blood pressure. So you have to manage the liaison with cardiologists, but this is very rare but not uncommon. Biphasic reaction. I just want to talk about biphasic reaction. So once you given developed anaphylaxis and recurrent anaphylaxis, this happen even the recurrent anaphylaxis symptoms may occur within 24 hours. So the same symptoms, they appear with the same low blood pressure, bronchospasm. So you need to observe this patient at least 24 hours in a setup. Possible risk factors include delayed administration of adrenaline and slow response to the adrenaline. And sometimes the patient who need repeated doses of adrenaline, they might develop the biphasic reaction. And patient who need vigorous resuscitation, they might develop biphasic reaction. So you can't treat now you can treat the patient now he's okay, so we can you can't keep the patient unmonitored. You have to keep the patient monitored. The other things, antihistamine, H2 blockers, corticosteroids, those are later on, and intubation in the severe bronchospasm. Okay, key messages. The early recognition of the anaphylaxis is very important because it's highly likely it can prevent the cardiac arrest. And we have to be very careful about the mimicking anaphylaxis, conditions mimicking anaphylaxis. Skin and mucosal changes can be subtle and absent in about 20% of the patient. Adrenaline is the treatment of anaphylaxis, and some patient might need 4 to 8 liters of saline. You have to remove or stop the anaphylactic trigger, and antihistamine and steroid has no place in cardiac arrest. Don't waste your time. And if it is a cardiac arrest, you have to start advanced life support algorithm. No IM adrenaline. You have to go with the IV adrenaline. And in case of beta blocker poisoning, in case of people with beta blockers on developing adrenaline, think about giving glucagon intravenously. These are my references: Asia guideline and Royal Children's Hospital guideline and analysis of emergency medicine. Thank you very much. If you have any questions.